Thank you very much, and it's a great pleasure to be here again at the Bangkok Symposium. And I want to thank the organisers for inviting me to give this presentation on the considerations for vaccination in people living with HIV. So I just want to declare a couple of conflicts of interest. I'm currently running a clinical trial about the timing of COVID-19 and tetanus toxoid vaccinations in those starting immunosuppressive therapy. It's funded by the Medical Research Futures Fund, but it specifically excludes most people with HIV. My other funding sources are shown here, and I'm on advisory groups for both Merck and Scientia Clinical Research, which is a phase 1 unit that does lots of immunotherapy and vaccine trials. So today I wanted to cover the immunology and vaccine responses and how they are modulated by people living with HIV. I wanted to cover the general principles of vaccination in that group. And then I wanted to go through a range of recommendations in terms of vaccine scheduling and use in adults, in those who are pregnant, and in paediatric and neonatal populations. And then I wanted to finish off with some practical considerations and take-home points. So in terms of principles of vaccination in this group of people living with HIV, they should be fully vaccinated. We should be aiming to have all our patients fully vaccinated, and if they're not fully vaccinated, they should be encouraged to become up-to-date. And becoming up-to-date means that they may need to start courses of vaccination de novo, or they may need to participate in a series of catch-up vaccinations. The schedule for vaccinations in these people should include all the vaccinations that are recommended for their particular age group. And in general, live attenuated vaccines are contraindicated, particularly in those that are significantly immunocompromised with HIV. Live attenuated vaccines need to be very carefully considered in this group of patients, and they need to be avoided if they have low CD4 counts, less than 200 CD4, at less than 200 CD4 cells per microliter. And the use at higher CD4 counts of live attenuated vaccines needs to be assessed on a risk-benefit analysis. It is worth noting and remembering that there are no other specific contraindications in this population to vaccination over and above what is there in the general population. The risks of anaphylaxis, allergic responses, and other adverse events are not increased in this population with subunit vaccines or with RNA vaccines. And wherever possible, vaccination regime should be started as early as possible in the disease process, because the potency of these vaccines is going to be less the lower the immune competence of the patients, and that can be interpreted from their CD4 count. If you vaccinate people with a lower CD4 count, this may require extra boosting, and this can be assessed by measuring serology post-vaccination for selected vaccines, and boosting if they don't reach serological criteria. And in late patients who are immunocompromised and diagnosed late, it may well be worth, in certain circumstances, awaiting for immune reconstitution post the initiation of ART to get the biggest bang for your buck out of vaccination. And we should also remember people's partners and people close to them. All household members and close contacts of people living with HIV should be fully vaccinated. I now want to go through the scheduling of vaccines for various diseases that are recommended for people living with HIV, and they're really not that different to what we recommend for the general population. So in terms of vaccines for respiratory viruses, in terms of influenza, this should be given yearly, as it is to the general population, and those greater than 65 or with significant immunocompromise should receive adjuvanted or high-dose influenza vaccine. Some guidelines, but not all, recommend twice seasonal vaccination if people that are elderly or significantly immunocompromised, and that is in the greater than 75 years of age group. And in people living with HIV, again, the use of intranasal live attenuated vaccines is not recommended and should be avoided. In terms of COVID-19 vaccination, we should use the most recent variant booster that's available. Those boosters should be given yearly or 6 monthly if greater than 65 years of age or significantly immunocompromised. And if they haven't been vaccinated for COVID in the past, they should be encouraged to have at least one vaccination with either an mRNA vaccine, or if they're vaccine hesitant with mRNA vaccines, with the Novavax or the generic Covavax version of that vaccine, which is a protein-based vaccine, if it's available, acknowledging that it is not available in a lot of countries, including Australia. RSV vaccines, you can use any of the 3 available vaccines. They should be given to people living with HIV greater than 60 years of age, and they should receive 1 dose of that vaccine. And the measles, mumps, and rubella vaccine, you should check the vaccine status and consider vaccination in people with high CD4 counts, that is greater than 200 cells per microliter, if there is a history of non-vaccination or of never having measles. But again, caution needs to be applied here, as the measles component of this triple antigen vaccine is a live attenuated vaccine and can have complications. In terms of vaccination for sexually transmitted diseases and bloodborne viruses, for human papillomavirus, we should ensure that people between the ages of 9 and 45 have an up-to-date 3-dose vaccine course. Although there are data arising around shorter vaccine courses, this approach has not yet been recommended in people living with HIV, but maybe in the near future. For hepatitis B, we should vaccinate those adults that are seronegative, and they should receive 4 vaccine doses. And after those 4 vaccine doses, we should check the serology about 4 to 8 weeks after the last dose. And if the titers remain low, below the level shown there, we should proceed to an extra dose to try and boost that immune response, that antibody to surface antigen above that critical level. In terms of Mpox, we should use the replication deficient modified vaccinia ankara vaccine from Jynneos. They should receive 2 doses subcutaneously 4 weeks apart. This vaccine is strongly preferred, and in fact to the alternative, which is the vaccinia vaccines for smallpox. Those vaccines are replication competent, such as the ACAM 2000, and are very likely to cause complications and possibly disseminated vaccinia infections in patients that are immunocompromised and should be avoided in people living with HIV. In terms of other vaccines for other viruses, patients should be encouraged to have the shingles or zoster vaccine, particularly if they're immunocompromised or in the older age groups. We should again avoid the live vaccine versions of these vaccines, and we should use the Shingrix vaccine with 2 vaccines 3 to 6 months apart. Polio vaccine should only be considered if a patient is travelling to an endemic area and their last dose was more than 10 years ago. And we should also consider vaccinating against hepatitis A with a 2-dose schedule if people are non-immune for hepatitis B and they have risk factors such as chronic liver disease, chronic hepatitis B or C infection, if they're living in or travelling to areas that are where hepatitis A is endemic, or they are men who have sex with men, or they have uncontrolled use of elicited substances. In terms of vaccines for bacteria, in adults, the pneumococcal vaccine should be given by a regime that starts with a dose of the conjugate vaccine, and this should be in addition to any vaccines that have been routinely received in childhood. And then they should also receive a dose of the polysaccharide-based vaccine 2 to 12 months later, and a second dose of that vaccine 5 years or more later. In terms of the conjugate vaccine, there is no preference and no data supporting the preferential use of the 13, 15 or 20-valent conjugate vaccines. In terms of meningococcal vaccination, again, the recommendation is to vaccinate both against the A, C, W and Y, as well as B strains of meningococcus. They should have a full primary course of the men ACWY vaccine. That's 2 doses, 8 weeks apart. Some of the trade names are shown there, with ongoing boosters every 5 years, and a full primary course of the men B vaccine, again 2 doses, 8 weeks apart, and a single booster 5 years thereafter. And then the vaccines against tetanus, diphtheria and pertussis, which are co-formulated, they should receive a booster dose if greater than 50 years of age and their last dose was more than 10 years ago. In terms of adults living with HIV, again, just to repeat, live vaccines are contraindicated, and so with cholera and typhoid vaccinations, you should aim to use the non-live options for vaccination against those infections. And while it's possible to use BCG, measles, mumps, rubella, rotavirus and JE vaccine and yellow fever vaccines, these should be used on a risk-benefit analysis. And again, should be avoided if severely immunocompromised. In terms of Japanese encephalitis, there is a subunit vaccine that can be used if travelling to an endemic area. And in terms of yellow fever, I think a strong discussion with the patient about the risk-benefit analysis and the necessity of travelling to a yellow fever endemic area, I think needs to be had in the context of their extent of immunocompromise before proceeding with the yellow fever vaccine, and the patients need to understand the risks associated with that. I now want to deal with pregnant people living with HIV. This table is a quick summary of the recommendations for people to refer to, but I'm going to go through this table in some detail now. So in terms of influenza vaccine, influenza vaccines are recommended for all pregnant women at any stage of pregnancy, and particularly those who will be in the 2nd or 3rd trimester of their pregnancy during the influenza season. Pregnancy increases the risk of severe influenza, and influenza immunisation protects both the mother from severe influenza during pregnancy, but also protects the neonate during the first months of life, and so is very important. And Importantly, there is no clinical trial or observational data that suggests an increased rate of congenital defects or adverse effects on the fetus of vaccination with flu vaccines. In terms of the diphtheria, tetanus, acellular pertussis vaccine, a single dose, booster dose of this is recommended from midway through the second to early third trimester of each pregnancy, and ideally that should be performed between 20 and 32 weeks of gestation. Vaccination reduces the risk of pertussis in pregnant women and their infants by over 90%, and so it's very important and very effective. But optimal protection is provided if the vaccine is given soon after the 20-week stage of gestation, and protection is lower if the vaccine is given within 2 weeks of birth. And again, the use of this acellular version of the vaccine is associated with no adverse pregnancy outcomes no adverse pregnancy outcomes. In terms of COVID vaccination during pregnancy improves maternal outcomes from both the Delta and Omicron infections, and that's in terms of reduced maternal hospitalisation and reduced admission to coronary care units, reduced preterm birth, and reduced neonatal mortality, as well as reduced ICU admissions. And these are reasonably recent data published in JAMA from a large cohort study late in 2025. In terms of the RSV, in this population, we should use the protein subunit vaccine only rather than the alternatives, including the mRNA vaccine. It's recommended that pregnant people receive a single dose from 28 weeks of gestation, and preferably for that to occur between 28 and 36 weeks. Whether that needs to be repeated during each pregnancy is currently a matter of debate, and that recommendation is to be confirmed. But clinical trial data show that a vaccine efficacy of about 60% in infants born to mothers that have received the Pfizer vaccine, and this is measured against hospitalisation for RSV for up to 6 months, for up to the first 6 months of life. Vaccination before 28 weeks is not recommended because, as a precautionary approach, due to an imbalance in the number of preterm births and neonatal deaths that was noted in a trial of an RSV vaccine conducted in low and middle income countries of a RSV vaccine that was no longer in development. So that's a note of caution, and the reason for doing that after 28 weeks. While vaccination after 36 weeks is permitted, protection is lower if given within 2 weeks of birth. So it's important to aim for that 28 to 36 week window. In terms of pneumococcal vaccines, these are not recommended in pregnant women, or not generally recommended in pregnant people. Women of childbearing age who have the risk conditions for for severe pneumococcal disease are recommended to have their vaccines either before a planned pregnancy or as soon as possible after delivery. The data on the various pros and cons of the 13, 15, 20-valent conjugate vaccine or the polysaccharide vaccine in pregnant and breastfeeding women are currently limited, but they're unlikely to induce adverse events. And risk-benefit analysis needs to be taken to vaccinating women, pregnant women who are at the highest risk of pneumococcal disease, who were not vaccinated prior to pregnancy. And importantly, breastfeeding women can receive any of the conjugate vaccines and also the polysaccharide version of the vaccine. I now switch to children living with HIV. Children with HIV for hepatitis B, they're recommended to have 3 doses of the adult formulation of the hepatitis B vaccine, so that's double the recommended dose for children that are not living with HIV. And again, you can check the levels of surface antigen antibody levels after the vaccination course and give further boosters if that's required. In Hep B endemic areas or in mothers that are surface antigen positive or in countries that are pursuing universal coverage of neonatal vaccination for hepatitis B, infants are recommended to receive 4 doses of the hepatitis B vaccine consisting of 1 dose of the monovalent vaccine at birth and then 3 doses of the pediatric hepatitis B vaccine at 2, 4 and 6 months, and that is usually given as part of a combination multi-component vaccine that includes tetanus, pertussis, inactivated polio and Hib. And there are a range of formulations of those combination vaccines, and there is no preference for which of those formulations you use. What's the rationale for a universal hepatitis B vaccine birth dose, which is currently recommended by WHO? It prevents vertical transmission from a mother with chronic hepatitis B. It recognises that there may be delays or errors in making that diagnosis, and so it prevents unrecognised transmission, or where it's known, failures in where the status is known and is positive, failures in reporting or communication of that status. It also prevents horizontal transmission to the infant from people with chronic hepatitis B who are close contacts. In terms of this procedure, neonates should receive the birth dose as soon as they're medically stable and preferably within 24 hours. But the vaccine can be given at any time during the first 7 days of life, but preferably should be given before discharge from an obstetric hospital or the delivery unit. In terms of children living with HIV and pneumococcal vaccine, the 20-valent conjugate vaccine in a 3-dose schedule at 2, 4 and 12 months is recommended. And if you've started the vaccination process with the 13 or 15 valent conjugate vaccine, you finish the course with the 20-valent vaccine if it's available. In terms of Haemophilus influenza B or Hib, a 4-dose regime at 2, 4, 6 and 18 months is recommended, same as for the general population. Again, this is given at 2, 4 and 6 months as part of a multi-component vaccine, and again, there is no particular preference for the version of that vaccine, but the 18-month dose is usually given as a monovalent Hib vaccine. What's the role? That's all active vaccination. What's the role of passive immunisation in children? Well, for RSV, the administration of prophylactic monoclonal antibodies is recommended for young infants whose mothers did not receive the RSV vaccine in pregnancy, who were not vaccinated within 2 weeks of giving birth, or for young infants that are at increased risk of severe respiratory syncytial virus infection, regardless of their mother's vaccination status, or in children less than 24 months who have medical risk factors for severe RSV. And this is a list of some of the examples of those specific conditions And you'll note that T-cell immunodeficiency is one of those significant immunosuppressions. And so babies born with HIV, and particularly those that are not receiving antiretroviral therapy, should be targeted for prevention of RSV disease. So that's all I wanted to say about scheduling. We need to admit that there are various barriers to vaccination, and in fact those barriers are increasing over time rather than decreasing. Unfortunately, there is an increased rate of vaccine hesitancy among most populations. And my approach is really one of support and education of those vaccine hesitant patients with gentle persistence in messaging. I think you need to be careful in terms of the messaging so as not to break the therapeutic relationship over this debate that you have with your patients. But I think you need to be persistent and creative in your education with the patients who are vaccine refusers or vaccine hesitant. There are also issues about cost and availability, and I suspect that many of you, as I went through those recommendations, were thinking that some of this is problematical. And we need, again, to acknowledge, like with some of our therapy, many of our therapies, that many of the recommendations for vaccines are not consistent with what are on subsidised public health lists and are not necessarily cheap. And in fact, many of these vaccines are extremely expensive and at times difficult to access. And so really my approach there is to prioritise those that are affordable and get those on board first. In terms of, there's also problems with those subsidised vaccines in that often certain groups need to administer those vaccines, and that complicates the patient care pathway in that they have to go to several places for their care, including their vaccines, which is another barrier which really we should be overcoming locally. And then there's also the problem of what are reliable and accessible records of vaccination for our patients, and often this data comes from history, and we know that that's unreliable. And so improving the accessibility to records of vaccination for our patients is very important. So what are the take-home messages? Vaccination is essential for HIV care. In general, the scheduling for people living with HIV is similar to the recommendations for the general population. All inactivated vaccines are safe at all CD4 T-cell counts, but live vaccinations require risk-benefit analysis and assessment of adequate immune competence, and where possible should be avoided, and the use of alternatives should be explored. And I recommend using the WHO and local guidelines such as the Australian National Immunisation Handbook for updates. And I'll just show those references that I used to put together this talk. Thanks very much.